Okay, thank you. So first of all, great audience here. Thank you all for getting up to listen to all these wonderful lectures this morning, and thank you to my chairs and the panelists here. So first off, this is the title of the paper, and this paper is actually published at the same time here. So if you want to look at the QR code, you can download the paper right now, but we were able to get co-publication, so thank you to JSCAI for that. I do want to thank my co-authors here. It's a very tight group of authors here, many of whom are in the audience here. It was a very tight writing group, and they did a phenomenal job on this paper. So this story in my mind at least, all started with the SCAI shock definition, and we've gone through this quite a bit over the last 5 to 6 years. But what has happened in my mind really is that although we know that this pyramid has made sense, and we heard that the NIH has now adopted this pyramid, which is great, what has really stood out with the pyramid is the pivotal role of lactate. So you see here that at stage C, lactate is elevated, and this is the time where perfusion is a problem. So it became very clear to all of us that hyperperfusion was the real problem that's causing higher mortality. If you can keep perfusion at bay and improved, then these patients typically would theoretically do well. And as we updated the definition in 2022, you all know that we went through physical exam findings, bedside findings, biochemical markers, and hemodynamics. And we struggled with the action or the issue that many of these things are very vague. Mottled skin, clammy skin, cold perfusion, mental state, renal function lags behind. But if you look at the biochemical markers, there's one thing that seems to be very accurate and very rapid, and that's the lactate. And as we went through in 2022 this document, it became very clear that in the biochemical markers, lactate was very obvious, very objective, very easy to draw. And so in retrospect, this document pushed lactate utilization and targeted evaluation and management all over the community. In our own hospital, we weren't doing much lactates before 2019. I'm sure most people were not. And then all of a sudden, people were doing a lot more. Why? Because the SCAI shock stages showed that it was probably important, certainly in diagnosis and evaluation. And if you go through A and B, it was normal. And then if you go to stage C, you see the lactate is now over 2. And then as you go higher up, it stays high, and this is the problem. So one thing was lactate became important, and we started understanding the utilization of lactate, both in diagnosis and in treatment, because if the lactate cleared, we then, on treatment, we then called it stage C, that they went down to stage C, but they could not go down to stage B until the devices or the support was removed. The second part that we realized is that shock is very fluid. So you don't just come in with shock, you come in with shock that changes over the course of your admission. You may go from A all the way catastrophically to E, or you may go down up stage-wise to B, to C, to D, and then come down to C. So it's a very fluid process, and during that whole time, you're trying to keep the patient from getting worse. And we just assume that, of course, worse is worse. But how bad really is it, and how important is it to make sure that your SCAI shock stage stays as low as possible? So we see this in some of the data. This is from the Mayo Clinic showing that even among survivors, it is very important that your SCAI shock stage is as low as possible. You'd rather be a stage B at your worst, a stage C at your worst, than a stage D or a stage E, even if you survive. And I draw your attention to the one-year mortality. It's very clear that not all survivors are the same, and you want to make sure the patients get better in the hospital and have the lowest SCAI shock stage. And even recently, and that was retrospective data, in the more prospective randomized controlled trial of the danger shock trial, everybody was scratching their head on why curves might continue to separate, even though these are low numbers. Why would curves continue to separate after the admission and after survivorship? Well, it makes sense to me that if you are worse in the hospital, even if you survive, you will probably be worse over life. We tend to want to think that if you survive an issue like a car crash or something else, you go back and reset to the same time point. The truth is, you probably have some subclinical damage to different organs, and that will affect you in the long term. So it becomes very important to be as healthy as possible and have the lowest sickness as possible while you're in the hospital. And these are some of the quotes that came out from Dr. Moeller saying the survival curves seem to keep separating beyond 30 days, and that's something to look at. And this is my quote from TCTMD, that not all survivors are the same, probably. If you have a more severe case of shock that you survived from, chances are you had more damage to different organs during that process, and that damage will probably reset you at a lower point in your life expectancy than someone who didn't have that kind of damage. It makes sense. And so it makes sense to be more aggressive in the hospital. And I give credit to Dr. Basir that we learned this very early in the NCSI, that even if you come in SCAI shock stage E, if you can get yourself down to C, which means by definition lowering and normalizing the lactate, you will have a survival of almost 80%, which is the same as C and D. Think about that again. People who are crashing and burning, if you do turn them around quickly, they have a survival of 80%. We never see that. And so something is happening here with aggressive care. So what are the unmet needs? Number one, early diagnosis in clinical settings. And I think we're going to be updating the SCAI SHOCK classification again as a third iteration, 2026 SCAI. Hopefully it'll be done by then, and we're going to go through this. And the wonderful talk right before us is going to inform that for sure. Number two, efficient assessment to minimize SCAI SHOCK stage. That's what I'm focusing on. Proven treatments by phenotypes and etiologies. That's what Dr. Naveen Kapoor and others are focusing on. And shock teams, Benham, other people like that, Alex, all focusing on shock teams. We all have to work together. But I'm going to focus in this document about efficient assessment to minimize the SCAI SHOCK stage. So what is lactate? Lactate, L-enantiomer, is a byproduct of anaerobic metabolism. It's widely produced at low levels under basal conditions. That's why it's not zero. Hypoxemia causes glycolysis of glucose to pyruvate, reduced by lactate dehydrogenase, goes to lactate. It's normally excreted, cleared by metabolically through the liver and kidneys, not by excretion, but really metabolically cleared, more than 90% that way. So it's very reliable and not related to, for example, kidney failure in and of itself. And there are two types of lactic acidosis. Type A, which is what we're talking about, hyperperfusion related, causing anaerobic metabolism, increased production, and some reduced clearance if there's liver involvement. And type B, which is really normal perfusion, but increased production or decreased clearance. So A is the most common one, but you have to watch out for B. Here's the data that we have. So when we first went on this endeavor, people said, where's the data? Well, the data is only recent because it's only about 5 years that we cared about lactate. Interestingly, in sepsis and other disease states, they've been caring about lactate for a long time. And my new chair of medicine is a sepsis expert, and he looked at me and said, well, we've known this for a long time, as an aside. So we should do some more cross-pollination, and we will be doing that at our institution. So the CARD shock registry, 2,017 patients with AMI cardiogenic shock, baseline lactate, and 6, 12, 24-hour lactate predicted 30-day mortality, 50% improvement in lactate at 24 hours predicted survival. The IBP Shock 2 trial, at 8 hours, lactate was the strongest predictor of mortality, and poor lactate clearance was predictive of death. NCSI, we already saw this, lactate 12 to 24 hours after MCS predicted in-hospital mortality. The danger shock, as I already showed you, the microaxial flow pump lowered lactate compared to the standard of care, and I think that that's the reason why these patients did better long term. Dorami trial, complete lactate clearance, percent lactate clearance, and percent lactate clearance per hour all predicted survival, with complete clearance the strongest predictor. And in retrospective cohorts among 1884 patients, 1 point increase in lactate increased mortality, 9%, 24-hour lactate clearance strongly predicted survival, and a meta-analysis of 1,500 patients, clearance within 24 hours predicted survival. And look at the other literature. We've known this now in hemorrhagic shock, septic shock, and burn-related injury. And a randomized controlled trial in sepsis of trying to check lactate every 2 hours and clearing it based on that targeted directory at lactate at over 8 hours resulted in improved mortality, shorter ventilation, and shorter ICU stay. So again, something that maybe we should be looking at in shock. Just to show visibly from the paper, this was the proof. Paper is now out formally. This is all the data about shock and lactate. You see these two big tables that have quite a bit of data, in my opinion. So what did we decide is the total lactate clearance? Well, this means the clearance of lactate with down below 2 within 24 hours of SCAI shock stage C, D, or E, where lactate is elevated. Now, that might mean different things in different subsets. So in AMI shock, that usually is on admission, because it's an acute event, or within 24 to 48 hours of admission for large anterior MIs and whatnot. For heart failure cardiogenic shock, it's probably more variable, so you have to be vigilant, and can be on admission, but can be at any time during hospitalization. That's where the SCAI stages come in. So here's the central figure from the paper. I want to take you through this. So SCAI shock stage A and B. So you want to be watching all the patients that come in and draw lactate on all of them. If you're right and the lactate is less than 2 in the SCAI A and B, you're good, supportive care. If the lactate is elevated, well, guess what? You're probably wrong, and this was SCAI stage C, and this was the reason to have A and B in the staging criteria. If you're stage C, D, and E, well, you have to start treating the patient, and then we recommend that you do lactates every 2 to 3 hours. At this point, if the lactate clears less than 2, you're fine. If the lactate rises, rapid rising lactate with clearance less than 10%, or worsening clinical status, you escalate care. And you want to do this every 2 hours, and you want to change and kind of retool what your thinking is, get the shock team involved. If the clearance is less than 10%, but it looks like they're perfusing fine, you want to look for alternate causes of elevated lactate, and I'll go through that on the next slide. And if you find those alternate causes, you need to treat them. That could be a compartment syndrome. That could be a mesenteric ischemia, all things that happen in shock, right? So treat those things and then reevaluate lactate. Is it going down? You're fine. If it's not, escalate care. And all the way on the right, sometimes it's too late. And if it's too late, you should at least think about that. Here are the different things that can alter lactate, either in a good way or a bad way. Renal replacement therapies can decrease lactate, so in that case, you want to still look for other signs of perfusion. Balloon pump, ECMO, Impella, and other flow pumps will decrease lactate appropriately. Focal end organ ischemia, gut ischemia, extremity ischemia, compartment syndrome, these things will increase lactate, and you have to treat that. That's a surgical problem that needs to be treated. And no matter how bad the patient looks, they always get better after that, in my opinion. And liver failure. True shock liver will elevate the lactate. But shock that happens where the lactate goes up, and as the LFTs come down, we've all seen this, the lactate will clear. So you want to watch that if you think it's from that. So I'll end with a call to action in future directions. Number one, after suspecting and diagnosing shock using the SCAI SHOCK Classification, assessment of tissue hyperperfusion with serial lactates toward clearance within 24 hours appears to be important. Number one, it may prevent both inappropriate escalation of care, and this has been helpful to me. If the lactate's clearing and we're not sure what's going on, don't do anything more. They're doing okay, and that helps. You avoid inherent risks of aggressive therapy when it was not necessary, and allow for timely and optimal escalation and de-escalation, including transfer if appropriate. Number two, should help reduce the severity and duration of shock, thereby, in my opinion, potentially improving both short and long-term survival, as we're seeing. Number three, and this is important, it's scalable to different hospital sizes and resources globally. I think it's very important to understand that if you're in India or in rural New York or anywhere else where you have less resources, you all have this. And at least you can understand how bad is bad and whether you need to transfer the patient. Number two, regional shock systems and teams should consider DLC in their algorithms, including early transfers for failure to improve lactate in the first few draws. So I put that time in. This is just a suggestion that over the first few, based on the septic shock literature, you should know which way you're going, and if you're not, maybe consider transferring that patient. Most of the big centers, the big problem is that patients are transferred very late. And if you're transferred late and you're in high levels of shock, you have less options, and we already know that. So if you can do more of this in the first 24 hours, that means it calls on government, SCAI, other organizations to try to put networks together, not just within hospital systems, but across hospital systems to expedite care within a time frame. If you can do that within your hospital system, fine. If you can't do that within your hospital system, maybe you tie with other hospitals. It's better for the patient, and that's where government's going to come in, and I'm going to be working on some of that in New York. Being mindful of the caveats that may reduce or elevate lactate out of proportion to tissue perfusion, as I mentioned. Clinicians and healthcare systems should consider making rapid point-of-care lactate ubiquitous. That means their EMS, that means the ER, that means critical care, cath lab, every location where you want to assess patients every 2 hours, even if they're going between places, should have the ability to have it. It comes back in 30 seconds. And number five, this is the most important. This was a stab. This was a shot in the dark based on the available literature. There's a lot of observational literature, but no prospective literature. So we're a little proactive here. We're a little bit trying to push the envelope of where we should go. Retrospective database reviews, prospective real-world registries, and randomized trials should consider evaluation of DLC and other markers. Maybe we're wrong, maybe we're right. I think we're right, but maybe there's something else that's better. But I do call on the field to do that. Thank you for your attention.